Good morning, and welcome to our second news conference of ENDO 2019. This one's going to be on reproductive health and the latest research in that space. I'm Jenny Glenn Gingery. I'm the Associate Director of Communications and Media Relations for the Endocrine Society. We're really pleased to have you all here for this discussion, and we're delighted to have with us some very prestigious speakers. We have Dr. Chana Jayasena from Imperial College London in the UK, Amir Zamanipur Najababad, an MD PhD student at Leiden University Medical Center in the Netherlands, and Keena Thackeray of University of California, San Diego School of Medicine. So over the next 35 minutes, each presenter will be presenting their findings, and at the end of those, we will have one Q&A session for the group. Please note that our news conference is being webcast right now live. There's many journalists with us online, so when you speak, we do ask that you speak into a microphone so that they can follow the conversation here in the room. And journalists, for those of you who are attending online, welcome. And please feel free to type your questions into the web chat, and we will make sure to get to those during the Q&A. I would now like to invite our first presenter, Dr. Jayasena, to the podium.
Thank you. I'm very pleased to tell you about some recent research we've been doing in London, trying to investigate new causes of a very common but desperately devastating condition that affects 1 to 2% of couples called recurrent pregnancy loss. So recurrent pregnancy loss is where a couple loses 3 or more pregnancies in the first half, the first half of gestation, so before 20 weeks. It affects up to 1 in 50 couples. It's absolutely devastating, and currently we know that there are several causes in women that can cause recurrent pregnancy loss, such as having an autoimmune condition, a tendency to thrombosis, so clotting, infections, etc. But over half of these cases of recurrent pregnancy loss, RPL, are unknown. They are idiopathic. And we've been very interested in seeing whether the male partners of women with recurrent miscarriage may have a role to play. So there's a bit of there's a scientific background to this, because we know that sperm DNA plays a very important role in placental formation. So it seems logical to pursue this route. And there have been previous studies showing that sperm DNA damage, so the genetic information in sperm which will lead to fetus and children, if that is damaged, then that can lead to fertility problems as well. So we know from observational studies that recurrent pregnancy loss, RPL, can arise from problems in male fertility, such as caused by infections in the prostate or the semen, heating of the testes, which can damage sperm production, or obesity. But we've never really known what's in the middle, why. And so we hypothesized that sperm DNA fragmentation, a recently identified method for measuring the level of genetic damage to sperm, could be a cause. And also reactive oxygen species, so oxidative damage, oxidative stress in the semen, which again has been identified as a major pathway for causing sperm DNA damage, could that be implicated as well? So to summarize our methods, we compared 50 men whose partners had had recurrent pregnancy loss with 63 healthy, unaffected men in our clinic. We did traditional microscopic semen analysis to look at the health, the movement, the concentration of sperm. We used an in-house measurement using luminol, which is a luminescent compound which changes color the more it's oxidized, to measure oxidative damage. And we also used a kit assay for sperm DNA fragmentation. So it's healthy for sperm under certain conditions with appropriate chemicals to have a characteristic halo. That is a healthy sperm. Whereas if the DNA is damaged, you get the loss of the halo. So these are the methods that we used. So looking at traditional sperm characteristics down a microscope, what we found was that the total number of sperm that were moving, shown in red in the recurrent miscarriage group, was lower, which is bad, compared with the controls. The number that were moving fast, so progressive motile sperm, was also lower in the RPL group compared to the controls. And the number who had normal morphology, so in other words, healthy-looking sperm, was lower in the RPL group, shown in red here, compared with controls. So this suggested that some of the most important aspects of how sperm looked and worked using traditional means were impaired in men who were affected by recurrent pregnancy loss. Looking at these novel sperm molecular parameters, so sperm DNA fragmentation was, the rate of this was doubled. So in other words, men who had recurrent pregnancy loss had a twofold increase in sperm DNA fragmentation compared with unaffected men. And the measure of oxidative damage using luminol, that was 4 times higher in affected men versus unaffected men. So in summary, this small study proves the concept, we think, that men whose partners have recurrent pregnancy loss may play an important role in this condition in some cases. So these men, compared with unaffected healthy men, had poorer moving sperm, which is associated with poor pregnancy, lower morphology, which again is associated with poor pregnancy, and higher rates of oxidative damage, so ROS, and higher rates of DNA fragmentation. I think this has important implications which may start to come through clinical guidelines soon, certainly in Europe, which is to actually argue that there should be some form of routine testing for men whose partners have recurrent miscarriage that is at least unexplained. And it also attractively opens new avenues, because if we can identify new ways, new molecular mechanisms by which recurrent pregnancy loss occurs, then we have what we call novel therapeutic targets to which we can design drugs to act against them. Thank you.
Thank you, Dr. Jayasana. And I'd now like to have Mr. Zamanapur Najafabad come to the podium.
Yes, thank you, Jenny, for the introduction. So I would like to use the next couple of minutes to present the results of our systematic review and meta-analysis on the effects of opioid exposure, opioid use, and the endocrine system in humans. So I have no relevant disclosures for this talk. We know that the use of opioids is increasing tremendously the last years, and it will only increase in the future. And we also know that patients using opioids, that it affects their endocrine system primarily by affecting the hypothalamus, that then regulates the anterior pituitary gland, which basically orchestrates the whole endocrine system by regulating different organs in the body, producing hormones, regulating all kinds of bodily functions. What we also know is that patients using opioids have lower quality of life compared with controls, partially due to these endocrine effects. So because the number of opioid users is increasing, and because we assume that by treating patients with opioid-induced endocrine deficits, we might improve their quality of life, we wanted to know the frequency of these endocrine effects due to opioid exposure. And to that extent, we performed a systematic literature search using current guidelines by the PRISMA group. We started with more than 2,000 already published articles, eventually included more than 1,100 unique records, screened them, and eventually included 52 articles describing an effect of opioids on the endocrine system. These articles were primarily published in North America, Europe, and Australia, so we're really missing quite some data from countries all over the world. Patients included in these studies were very heterogeneous. The majority of the patients were opioids maintenance after opioid addiction. Different types of opioids were used by these study populations, and also the endocrine assessment of the different hormones varied a lot. And even different studies assessing the same hormone could use different methods to do this, and it could affect their results eventually. So first of all, the results on the gonadal axis. And the gonadal axis is the axis that is primarily responsible for the production of sex hormones. We could include 15 studies describing more than 3,000 patients. And of notice, most of these patients were male patients. So we're talking about testosterone levels. And in these studies, the number of patients, the percentage of patients with insufficient levels of testosterone varied between 36% and sometimes 100%. And when we wanted to pool these results to get a weighted average, we saw that 65% of male patients using chronic opioids have insufficient levels of testosterone. Then the results on the corticotropic axis that is responsible for the production of the stress hormone cortisol, which is of life importance, especially in periods of adaptation to disease and stress. We could include 5 studies describing 207 patients, and in these studies, male and female patients were almost equally represented. And between 8% and 35% of these patients had lower levels of cortisol, insufficient levels. And again, when we pooled these studies to get a weighted average, we saw that 19% of these patients had insufficient levels of cortisol. So almost 20% have insufficient levels. Possibly these patients might suffer from symptoms like fatigue, psychological issues, and muscle weakness. And regarding the low levels of testosterone, in 65% of patients, this also can cause muscle weakness, but also less sexual drive by lower levels of libido, impotence, and erectile dysfunction. We also looked at other endocrine hormones, for instance, prolactin causing lactation. And we found in 5 out of 7 studies that patients had higher levels of prolactin. And this doesn't only have consequences for lactation, it might also suppress actually the gonadal axis, and therefore patients might suffer from symptoms like infertility. Regarding 2 other hormones, growth hormone and thyroid hormone, we couldn't make any definitive conclusions based on the already published literature. So I think we really need to use this information to acknowledge the symptoms that our patients might have by treating them with opioids. And this information can also be used to maybe discourage people who are using opioids to just get into a euphoric state, because it goes in the expense of their sexual function. For the future, I would really like to encourage the endocrine society worldwide to assess the relationships I just described, to the relation between the deficiencies and the actual experienced symptoms by patients, using prospective studies measuring patient-reported outcomes so we really know what patients are suffering from and the severity of their symptoms. Using this information, we might be able to select the patients that are at high risk for developing these deficiencies. And eventually, we need to assess the added value of screening, because we're talking about millions of people in the US and worldwide. So we really need to know screening and possible treatment of their deficiencies. So for instance, testosterone depletion and deficiency, or hydrocortisone depletion when they are cortisol deficient. Does it really affect the outcomes? Does it improve the quality of life? And what are the costs? So I would like to thank very much our first authors, Mees Bruin and Friso de Vries, who have been conducting this study, and also all the other colleagues at our center. Thank you.
Thank you so much. And I'd now like to invite Dr. Thackeray to the podium.
Thank you for having me talk at this press release. So I wanted to present our results from a collaborative study actually between folks at UC San Diego and San Diego State University in my lab and Scott Kelly's lab. So this is kind of addressing the question of whether the gut microbiome could play a causal role in polycystic ovary syndrome. So just to introduce PCOS, or polycystic ovary syndrome, this is a syndrome where women present with 2 out of 3 of the symptoms: hyperandrogenemia, anovulation or irregular menstrual cycles, and polycystic ovaries. These women have fertility issues, miscarriage and pregnancy complications, as well as a risk of developing metabolic diseases such as type 2 diabetes, gestational diabetes, hypertension, and non-alcoholic fatty liver disease. So it made us wonder whether there was an association between the gut microbiome, which is starting to be shown to play an important role in metabolism, and these metabolic symptoms in women with PCOS. So initial studies over the past 2 years have shown that changes in the gut microbiome are associated with PCOS. And this has been shown in over 4 or 5 studies in women with PCOS as well as in rodent models. So just to kind of summarize here, the healthy microbiome has high biodiversity and lots of different types of microorganisms. What studies have shown is that the PCOS microbiome has less diversity overall and changes in the relative abundance of different bacterial families that are illustrated here. Importantly, what's also noted is that hyperandrogenism, which is one of the symptoms of PCOS, has been linked with changes in the gut microbiome. This suggests, since hyperandrogenism is also linked with the development of the metabolic symptoms, that the changes in the gut microbiome may also be associated with the development of the PCOS metabolic syndrome. So what we did in this study is we have a letrozole-induced PCOS mouse model. The letrozole results in the blockage of the aromatase enzyme, resulting in elevation of testosterone and lowering of estradiol. This is a 5-week model starting in puberty in which animals are implanted either with a placebo or a 3 milligram dose of letrozole. We then decided to perform a co-housing study, which would lead to the letrozole co-housed mice, or our disease model, being exposed to a daily low dose of feces from the placebo or healthy mice. So in this way, we had placebo mice that were co-housed together, letrozole mice co-housed together, and a placebo mouse co-housed with a letrozole mouse. And we wanted to ask whether exposure to the gut microbiome could have an effect on the gut microbiome, but also the PCOS phenotype. And to make a long story short, that's indeed what we saw. So, for example, in letrozole treatment, you see an increase in weight gain, which is typical of women with PCOS. The co-housing prevented this weight gain. In addition, for insulin tolerance, which, a measure of insulin resistance, the letrozole-treated mice are more insulin resistant. If they're co-housed or exposed to the healthy gut microbiome, they no longer display this insulin resistance. We also looked at the reproductive phenotype, hypothesizing that affecting the metabolic phenotype could maybe have an effect on the reproductive phenotype as well, and that's what we saw. So illustrated with the testosterone levels, letrozole treatment results in elevated testosterone levels. This is reduced with co-housing. The mice begin to cycle again, and you also have the appearance of corporal lutea in the letrozole mice co-housed with the placebo mice, suggesting that they're capable of ovulation. Finally, we looked at the effects of this on the gut microbiome itself, and looking, for example, at a parameter which is termed beta diversity. So this is how similar the gut microbiome communities are to one another. What you can see is that, sorry, I lost my mouse here. You can see that the letrozole-treated mice group together. So these are individual mice's microbiome, and this is suggesting that they're more similar. And then you can see that the placebo co-housed, and letrozole co-housed are starting to group together, suggesting that there is exchange of microbes between these two groups in the co-housing. We then also looked at specific bacteria that were involved in this exchange, and what we used is a DSEQ analysis that shows a log 2-fold change. And what this highlights is several different bacteria that were higher in placebo mice than in letrozole mice, and bacteria that were higher in letrozole mice than placebo mice. And then finally, we compared the letrozole mice with the letrozole co-housed mice. And we identified one bacteria, Coprobacillus, that was also changed here as well, suggesting that Coprobacillus potentially could be a probiotic that we could test as a potential treatment for protecting or preventing the development of PCOS-like symptoms in our model. What's interesting is Coprobacillus has been proposed as a novel probiotic, so we're very interested in following this up in future studies. So what our studies then show is that this co-housing approach suggests that the changes that we see in the microbiome is not just a result of PCOS, but it may actually play a causal role. So fundamentally, this is suggesting that modulation of the gut microbiome could be a potential therapy for PCOS. And we'd like to follow this up further in our mouse model with the eventual goal of developing new therapeutics for women with PCOS. Thank you.
Thank you so much, Dr. Thackeray. I'd now like to open it up for any questions. Again, we do ask if you could please speak into the microphone, wait till a staff member brings it to you if you're here in the room, and then please tell us what outlet you're with and identify yourself. Thank you. Any questions?
Hi, I'm Sherry Rowan with Everyday Health, and my question is for Dr. Jayasana. Can you just comment on whether you think male factors related to recurrent pregnancy loss are maybe not considered as often as they should be? I assume typically clinicians will look first for female-related factors. Do you think your study suggests that maybe male factors should be given more consideration?
That's a great point. I entirely agree. I think the root cause of why male factors, so male partners, may be overlooked is wider than the medical community and probably reflects society as a whole. And I think fertility is seen by many as the responsibility and burden of the female partner, and when it goes wrong, as the fault of the female partner. And I think this hopefully adds to a trend to indicate that the male partner does indeed play a great role and it's important, and there may be traction in trying to pursue investigation but also therapies in the future for the male partner to help both members of the couple.
Hi, Elizabeth Lavinka from MedPage Today. My question is for Dr. Naja Fawadi. So you briefly mentioned this at the introduction of your talk, but can you talk a little bit about the biological mechanisms that might be behind your findings? So why might opioids so frequently cause hypogonadism or other hormone dysfunction?
Yeah, so we know that from animal studies that chronic use of opioids might regulate primarily the hypothalamus, and hypothalamus is a part of the brain that is very responsible for regulating all kinds of bodily functions. Some extra proof for that idea is that that from animal studies it's known that there are some receptors at those brain areas like the hypothalamus that are especially for the opioids. So opioids can get on those receptors and by that regulating the hypothalamus. And the hypothalamus itself regulates the pituitary gland, which is a hormonal gland laying beneath the brain, and that basically regulates all kinds of organs in the body which produce the actual hormones that we're talking about. So that is probably the main mechanism.
Any other questions? I don't think we have any from our remote reporters either, so.
Great. Dr. Thackeray, I was wondering if you could just tell us what is the current treatment, what are the current treatment options for women with PCOS?
So for women with PCOS, in terms of their metabolic phenotype, there's actually not that many options, and so that's kind of part of our interest is whether we can develop some other options. So the first line treatment is basically diet and exercise, which is what we tell all women with metabolic issues, which is obviously a difficult therapy, and compliance is difficult as well. And then they add metformin if that is necessary, and as most of you probably know, metformin actually has a lot of side effects, so about 20% of people that take metformin cannot stay on the medication because of very strong gastrointestinal side effects, and even those who do stay on it, it's a difficult therapy. So I think the interaction between the gut microbiome and potentially metabolic disorders, including PCOS, really gives us an avenue to explore some different therapies. So for example, we could potentially consider whether a prebiotic, different fibers are helpful. If we can develop novel probiotics, those also could be helpful, as well as what was called so-called postbiotics, which are metabolites that are potentially produced by the gut microbes that also could be of interest. And just to note, the metformin, for example, has just been shown in a study to treatment of metformin results in changes in bile acids that are antagonists for the FXR receptor. So this is a potential avenue that we could pursue as well with women with PCOS.
Great, thank you. Great. If there are no other questions, we'll go ahead and wrap up today. Thank you so much to everyone who attended and to our speakers.